Okay, let's unpack this. Today, we're diving into something that, well, it touches almost everyone's life in some way, but it's still really misunderstood. We're talking about the hidden epidemic of post-traumatic stress disorder, PTSD, and also its more complex relative, CPTSD.
Yeah, it's a huge topic. And the numbers are pretty startling.
Yeah,
Globally, something like 70% of people might experience a traumatic event at some point.
70%. Wow.
Right. And look, it's completely normal, a human response to feel awful, overwhelmed after something dangerous happens. But for some people, and we're talking millions, that feeling, that distress, it just doesn't go away.
It gets stuck.
Exactly. It digs in, actually changes how the brain works, messes with daily life, sometimes years after the danger's gone.
So our mission today, our deep dive, is really to look at that specific point. When does a normal reaction become something more? We want to clearly separate, a typical stress response from clinical PTSD.
Hmm.
And then we need to get into complex PTSD, CPTSD, which is, well, it's complicated and even a bit controversial diagnostic.
It really is.
We'll look right into the brain, see what's physically happening when trauma takes hold, and then, really importantly, break down the best evidence-based treatments, what actually works.
Right.
We're drawing on info from places like the NIMH, the WHO, the VA, top medical centers.
Yeah, think of this as your shortcut to really getting informed, because this isn't some rare thing. In the U.S. alone, it's estimated, 13 million adults might have PTSD in any given year.
That's huge.
It is, and understanding the mechanics, the why behind it is so important. It helps you see this isn't a character flaw, it's more like a physical injury to the nervous system.
Absolutely. So, okay, let's start right at the beginning. Defining PTSD clinically. What's the trigger? And when does that normal reaction cross the line into, well, a disorder?
Okay, so clinically, PTSD is a mental health condition. It only develops after someone experiences or witnesses something traumatic, maybe life-threatening, or even something that just poses a huge threat to their physical or emotional well-being. And the disorder itself, what marks it, is this persistent, really overwhelming stress and fear that hangs around long after the actual danger is over.
Right, persistence. That's
Yeah.
the key word, isn't it?
Mm.
Because it's normal and expected to feel upset, anxious, maybe sleep badly right after something terrible happens. If that only lasts a few weeks, what do we call that?
So that's usually called an acute stress reaction. And actually, the vast majority of people, our sources say maybe 94.4% globally who go through trauma, they actually recover naturally.
Really? That high?
Yeah. Within a few weeks, they manage to process it, get back to their normal life, their baseline. PTSD is when the symptoms last longer than 1 month, and they're severe enough to really interfere with work, school, relationships, just basic functioning. That 1 month mark, that's the clinical line in the sand.
It's pretty fascinating when you look at the history here. I mean, descriptions of these symptoms go way back, ancient times even. But it took, what, a world war to really start formalizing it?
It did, yeah. We started seeing these symptoms on a mass scale in the military. First, it was called shell shock in World War I, which kind of reflected the physical impact of constant bombing.
Right.
Then later, it was things like war neurosis or battle fatigue. But it wasn't until 1980, actually, that PTSD became an official diagnosis. That was largely driven by research on Vietnam veterans, but also recognizing similar things in Holocaust survivors and victims of sexual assault.
So recognizing it wasn't just about combat.
Exactly.
Hmm.
It showed that the trauma response was universal, not just something that happened on a battlefield.
And even since 1980, the way we classify it has changed, right? Showing we're understanding it better.
That's right. For a long time, PTSD was kind of lumped in with anxiety disorders, mainly because, fear and being on edge, hypervigilance were such obvious symptoms.
Makes sense.
But then in 2013, with the DSM-5, the big diagnostic manual, it finally got its own category: trauma and stressor-related disorders. This was a big deal. It acknowledged that PTSD's effects are really unique and complex. They go beyond just anxiety affecting mood, how you think, even your sense of self.
Looking at the numbers, the prevalence data really drives home just how widespread this is. You said maybe 6% lifetime rate globally, but that risk isn't spread evenly at all.
Not at all, no. The risk really jumps depending on the type of trauma someone experiences. For people exposed to, say, violent conflict or war, the rates can be more than triple the average, maybe up to 15.3%. And it's also extremely high after sexual violence.
That data really helps bust the myth that PTSD is just a combat thing, right?
Absolutely. It can come from any major trauma, a natural disaster, a bad car accident, a serious assault, anything that fundamentally shakes your sense of safety and how the world works.
Okay, so we've defined it. Now, this is where I think it gets really interesting. Let's break down the ways PTSD actually shows up, the four main symptom clusters, right? This helps you kind of see the specific patterns.
Yeah, these clusters sort of map out the different ways that chronic stress messes with your emotional and mental life.
Let's start with cluster one, re-experiencing symptoms. Intrusion. It seems like the classic image of PTSD for many people.
It often is. Intrusion symptoms are things that happen against your will repeatedly. We're talking about distressing memories popping up, scary thoughts you can't shake, and probably most dramatically, flashbacks.
Flashbacks aren't just bad memories, though, are they?
No, not at all. A flashback is way more intense. It's like a full sensory replay. The person feels like the trauma is happening right now, all over again. It throws them straight back into that survival mode.
And it's not just during the day. Sleep gets hit hard, too, right? Nightmares are a big part of this cluster.
Oh, absolutely critical. Nightmares are really common, and often they're replicative. That means they actually replay the traumatic event itself. People wake up terrified, distressed. One study we looked at even called these replicative nightmares a hallmark of PTSD.
Why a hallmark?
Because it really shows the brain struggling. It hasn't properly filed that traumatic memory away as something that happened in the past. It's still live, still current in a way.
Okay, that unprocessed memory, that intrusion, leads right into cluster two, which is avoidance. Makes sense trying to shut down those horrible feelings.
Exactly. Avoidance is about actively trying to stay away from anything, literally anything that reminds you of the trauma. This can be external, like physically avoiding places or people.
Like maybe someone stops driving after a bad car crash.
Perfect example. Or it can be internal avoidance, which can be sneakier.
How so?
Well, internal avoidance involves things like emotional numbing,
Yeah.
feeling detached from people you love, losing interest in things you used to enjoy, or just refusing to talk about the event or your feelings about it. Some people might just keep incredibly busy, always distracted, just so those thoughts don't have a chance to surface.
Okay, that leads us to cluster three, arousal and reactivity. This sounds like the body being stuck in high alert.
That's precisely it. It's the fight or flight system basically stuck in the on position. Key symptoms here are hypervigilance, constantly scanning your surroundings, feeling like you're always on guard, waiting for something bad to happen.
And being easily startled.
Yeah, the startle reflex, especially to sudden noises, gets dialed way up. People might jump out of their skin at everyday sounds.
Our sources mention this cluster also includes irritability, sudden anger, trouble sleeping or concentrating, and significantly, reckless or self-destructive behavior was added more recently.
That was an important addition clinically, because that kind of behavior often reflects really desperate attempts to cope or feel something other than fear. If you think about, say, fireworks on the 4th of July,
Yeah.
that's a classic example of hyperarousal. For most people, it's just noise, maybe celebratory. But for someone with PTSD, especially maybe a combat veteran, their nervous system might instantly hear that as gunfire, as danger.
Wow.
They're thrown right back into survival mode. Maybe they get aggressive, maybe they hide. Doesn't matter that they're actually safe in their backyard. That constant state of alert, it's just exhausting. It burns up so much mental energy.
Okay, finally, cluster four, cognition and mood symptoms. This is about how the trauma changes how you think, how you feel about yourself in the world.
Yeah, this is where things can get really dark and rigid. This cluster covers ongoing negative thoughts or beliefs. Things like, I'm worthless, or the world is totally dangerous, nobody can be trusted.
Guilt and shame seem big here, too.
Huge. Intense feelings of guilt, shame, blaming yourself for the event even if it wasn't your fault. Also, sometimes people find they can't remember important parts of the trauma. And a really key thing is often an inability to feel positive emotions.
Yeah.
Joy, love, contentment, just this pervasive sense of doom or detachment.
So those are the four clusters. Let's shift gears a bit and talk about who gets affected most. The research shows some pretty clear disparities, starting with gender.
Yeah, there's a definite gender difference. Women are roughly twice as likely as men to develop PTSD. The estimates are around 8% lifetime risk for women versus 4% for men.
Why is that?
Well, it's often linked to the types of trauma women unfortunately experience more often, things like repeated interpersonal violence, sexual assault, domestic abuse. These kinds of trauma, especially when they involve betrayal by someone close, seem to be particularly damaging to a person's sense of safety and trust.
We also saw some striking data about identity-based trauma. For people in the LGBTQI community, the rate was mentioned as being over 40%. That's
Hmm.
incredibly high.
It is staggeringly high. And it highlights a crucial difference between a single acute trauma, like that car crash example, and chronic trauma. For LGBTQI individuals, the risk seems driven by a combination of things. First, sadly, higher vulnerability to violent attacks, but also this constant underlying stress from discrimination, prejudice, hate, sometimes called minority stress.
So it's not just big events, but the day-to-day grind, too.
Exactly. That chronic stress keeps the nervous system in a kind of constant low-level alert state. It affects self-worth, emotional regulation, sense of safety. It makes the whole system more fragile, more susceptible to breaking down into clinical PTSD if a major event does happen.
And then there are these traumas that are almost hidden in plain sight, right?
Yeah.
Like medical PTSD or postpartum PTSD.
Absolutely. Medical PTSD can happen after any really scary medical event, being on a ventilator, having a major surgery, or heart attack. One study found about 1 in 8 heart attack survivors ends up developing PTSD afterwards.
1 in 8. That's shocking. And what's the impact?
Well, it's devastating because those who develop PTSD are often much less likely to stick with the really important treatments they need for recovery. Taking medications, changing their lifestyle. The lingering fear actually gets in the way of healing.
That makes perfect sense. The psychological trauma hinders the physical recovery.
Precisely. And with postpartum PTSD, which can affect up to 4% of women after childbirth, often linked to really difficult births, emergency situations, or maybe lack of support, it can seriously interfere with that crucial bonding time between the mother and the new baby. It adds another layer of difficulty and heartache. And, if we connect this back to the bigger picture, that difference between a single traumatic event and chronic repeated trauma, that's really where complex PTSD or CPTSD comes in. And this is where things get, well, diagnostically tricky.
Right. So CPTSD comes from things like long-term childhood abuse or neglect, maybe being held captive, situations where the trauma wasn't just a one-off, but happened over and over, and escape felt impossible, like a siege, you said.
That's a good way to put it. A siege. That distinction is really important. CPTSD includes all those 4 PTSD symptom clusters. We talked about the intrusions, the avoidance, the hyperarousal, the mood changes, but it adds these deep chronic problems in 3 extra areas. The WHO, the World Health Organization, spells these out in their latest diagnostic manual, the ICD-11.
Okay, what are those 3 additional areas for CPTSD?
So first is difficulties in emotion regulation. This means chronic trouble managing feelings, really intense mood swings, volatility, finding it hard to control anger, sadness, even extreme joy sometimes.
Yeah.
Second is disturbances in self-concept. This is about persistent feelings of shame, guilt, feeling worthless or like a failure. It often leads to a really negative, kind of fractured sense of who you even are.
That sounds incredibly painful.
It is. And the third area is difficulties in relationships. Chronic problems forming or maintaining stable, trusting relationships. People might swing between avoiding closeness altogether and getting into really intense, unstable attachments.
And this complexity, these extra layers, that's what led to this diagnostic debate you mentioned earlier.
Exactly. It's a major point of difference between the big international health bodies. The WHO, as I said, officially recognized complex PTSD as its own distinct condition back in 2019 with the ICD-11. That was a big step, giving clinicians a clear way to diagnose the impact of long-term trauma.
But not everyone agrees.
Right. The American Psychiatric Association, the APA, which publishes the DSM-5, the manual used most commonly in the U.S., does not currently recognize CPTSD as a separate disorder.
Really? So what do they do?
Well, the DSM-5 does list a subtype called PTSD with dissociative symptoms, which covers some of the ground, especially the detachment and altered sense of self. But it's still classified under PTSD, not as its own thing. This creates challenges for clinicians and patients in the U.S. seeking specific recognition or treatment approaches for CPTSD.
So you have experts debating whether CPTSD, regular PTSD, and maybe even something like borderline personality disorder, BPD, because BPD also involves things like impulsivity and difficult relationships, maybe they all exist on a kind of spectrum, a trauma-related spectrum.
That spectrum idea is definitely part of the conversation. Clinically, differentiating them often comes down to the root cause. While BPD and CPTSD can look similar on the surface with relationship issues or impulsivity, the diagnostic focus for CPTSD, especially using the WHO's ICD-11 framework, tends to be more specifically on how the trauma led to attachment problems and that deep-seated shame and negative self-view. Whereas BPD might be seen as having broader personality factors at play, though trauma is often a factor there too. It's complex.
And does brain imaging show any differences between PTSD and CPTSD?
It seems to, yeah. Some neuroimaging studies suggest that the changes in the brain might actually be more severe or widespread in people with CPTSD compared to those with standard PTSD. Things like potentially greater shrinking in the hippocampus and maybe more disruption in how different brain regions connect and communicate.
Okay, this brings us to a really critical point. What is actually happening inside the brain and body when someone has PTSD? Because as you said, this isn't just in your head. It involves real physical changes.
Absolutely. The symptoms we've been talking about, they're the direct result of changes in brain structure and function, specifically in the parts of the brain designed to handle threat detection and response. We usually focus on three key areas.
Right. You mentioned the amygdala, the medial prefrontal cortex, and the hippocampus. Let's start with the amygdala, the fear center.
Exactly. In PTSD, the amygdala becomes overreactive, hypersensitive. It's basically sounding the alarm bells too often and too loudly. At the same time, another area, the medial prefrontal cortex, or PFC.
That's like the brain's control tower, right, for planning and judgment.
Yeah, it's the executive control center. In PTSD, the PFC often appears smaller or is less responsive, less active.
So if the control tower isn't fully operational, what does that mean for managing the fear signals?
It means the brakes aren't working properly. The PFC is supposed to assess the situation, use context, and calm down those raw panic signals coming from the amygdala. It's meant to say, okay, hang on, that loud noise was just a car backfiring, we're actually safe now. When the PFC isn't doing its job effectively, you lose that top-down control. The amygdala runs wild, leading to that chronic fight-or-flight state, the hyperarousal.
And the third part, the hippocampus, how does that fit in? It's involved in memory, right?
Crucially involved in memory and emotion, yes.
Yeah.
And really important for providing context. The hippocampus helps you tag memories correctly, distinguishing between something scary that happened in the past and something dangerous happening right now.
Yeah.
Research consistently shows that in people with PTSD, the hippocampus can actually shrink in size. When that happens, the ability to contextualize trauma memories gets impaired. The brain struggles to label memory as past and safe. This directly contributes to those re-experiencing symptoms like flashbacks, where the past feels terrifyingly present.
So that constant feeling of being on edge, that the system is always on fire, that's rooted in chemical imbalances too, particularly with stress hormones.
Yes, but it's a bit nuanced. We often talk about the HPA axis, the hypothalamus-pituitary-adrenal axis. That's the body's main stress response system. Now, you might think people with chronic PTSD would have super high levels of cortisol, the main stress hormone.
Right.
But often, counterintuitively, they actually show normal or even low levels of cortisol in their bloodstream over the long term.
Low. Why low if they're so stressed?
It's complex, but one theory is that the system becomes so chronically overstimulated and sensitive that the feedback loops get altered. It might kind of burn out or recalibrate to a lower baseline cortisol level, but that doesn't mean the initial stress trigger is gone.
So what is driving that constant feeling of stress then?
A key player seems to be elevated levels of something called corticotropin releasing factor, or CRF. This is released higher up in the chain in the brain. CRF acts as a major trigger for the release of norepinephrine.
And norepinephrine is?
Norepinephrine is that fast-acting chemical messenger that gives you the immediate physical jolt of stress. The racing heart, the higher blood pressure, the jumpiness, that feeling of tension. So even if cortisol is low later on, this constant bath of norepinephrine, driven by high CRF, keeps the person feeling wired, amped up, on edge.
Like running a nonstop low-level marathon even when they're just sitting there.
That's a really good way to describe it. And we also see changes in other important brain chemicals. Things like GABA, which normally calms the brain down, its function might be impaired. Glutamate, the main excitatory chemical, might be overactive. And serotonin, which is crucial for mood, often gets dysregulated too, which helps explain why depression and anxiety are so commonly seen alongside PTSD.
What's really striking, and maybe scary, is how this chronic mental stress spills over and affects the whole body physically. It's not just a brain thing. It becomes a systemic health issue.
It absolutely does. That constant hyperarousal state leads to chronic inflammation throughout the body. We see elevated levels of inflammatory markers like certain white blood cells. And this isn't just minor irritation. This chronic inflammation is a major driver of serious diseases.
Particularly heart disease, right? The links there seem incredibly strong.
Shockingly strong. Research now clearly shows a powerful link between PTSD and cardiovascular disease, CVD. Having PTSD is associated with something like a 40% higher risk of having a heart attack and basically double the risk of having a stroke.
40% higher heart attack risk, doubled stroke risk. Those numbers are huge. How does that connection work physically?
Well, beyond the general inflammation, studies, especially looking at veterans with PTSD, have found something called endothelial dysfunction.
Okay, break that down. Endothelium.
The endothelium is the smooth inner lining of your blood vessels. Normally, it's really important for helping blood vessels relax and expand properly to control blood flow and pressure. In people with PTSD, studies show this lining doesn't work right. The blood vessels become stiff, they can't expand normally when they need to.
So they lose flexibility.
Exactly. And that loss of flexibility, that endothelial dysfunction, is a well-known early step towards atherosclerosis, the hardening and narrowing of arteries, and ultimately, heart attacks and strokes. It's a direct physical mechanism linking the psychological trauma to severe heart problems.
Wow. And speaking of physical factors, is there also a genetic component? Are some people just more biologically vulnerable to developing PTSD after trauma?
It looks that way, yes. There's growing evidence for genetic predisposition. Large studies like the Million Veteran Program, which looked at over 165,000 veterans, have been really important here.
What did they find?
They identified several specific locations on the human genome. They pinpointed genes with names like CAMKV, KNSL1, CRHR1, TCF4, SCA2, and FKBP5 that seem to be associated with an increased risk of developing PTSD, particularly linked to how severe those re-experiencing symptoms like flashbacks and nightmares become.
Interesting.
And interestingly, the overall genetic influence on PTSD risk seems to be somewhat higher in women than in men, suggesting a complex mix of biology, genetics, and maybe the types of trauma experienced.
And of course, trauma rarely happens in isolation. PTSD often comes tangled up with other problems, which must make treatment even more challenging.
Oh, absolutely. Co-occurrence is more the rule than the exception. PTSD very often travels with major depression, other anxiety disorders like generalized anxiety or panic disorder, chronic pain conditions, and, really significantly, substance abuse disorder.
Using drugs or alcohol to cope.
Exactly. Many people turn to alcohol or drugs to try and numb the pain, escape the hyperarousal, or just feel something different for a while. But unfortunately, substance abuse almost always makes the underlying PTSD symptoms worse in the long run and creates a whole extra layer of problems for recovery.
Okay, so we've painted a pretty detailed picture of how complex and physically impactful PTSD is.
Oh.
Now, let's shift to the good news. Despite all these changes in the brain and body, there are effective treatments. And interestingly, the first line of attack usually isn't medication.
That's right. Psychotherapy, specifically trauma-focused psychotherapy, is strongly recommended as the first-choice treatment for PTSD. The evidence consistently shows that these therapies are often more effective than medication alone, especially in the long term, and they generally have fewer side effects.
Trauma focus being the key phrase there.
Absolutely key. The therapy needs to actively engage with the traumatic memory itself or the distorted thoughts and feelings that came from it. Just general talk therapy often isn't enough to address the core issues of PTSD.
And there are a few specific types of therapy that are consistently highlighted as the gold standard, right?
Yes, there are three main ones that have the strongest evidence base. First, there's cognitive processing therapy, or CPT.
CPT. What does that involve?
CPT is typically a structured 12-session therapy. It really focuses on helping the person identify and challenge the unhelpful thoughts and beliefs that got stuck after the trauma. Those feelings of intense shame, guilt, self-blame, or distorted ideas about safety and trust. The goal is to help you change how you think about the trauma and its impact, which then changes how you feel.
Okay, changing the thoughts. What's the second one?
The second is prolonged exposure therapy, or PE. Now, this one can sound a bit intimidating because it involves confronting the trauma memories.
Yeah, confronting sounds intense, especially given the avoidance symptoms.
It is intense, but it's done in a very careful, gradual, and controlled way within the therapy session. PE involves repeatedly revisiting the traumatic memory in detail through imagination that's called imaginal exposure, and also gradually confronting safe situations or triggers in real life that the person has been avoiding that's in vivo exposure.
Why do that? Why confront it?
The core idea is habituation. By repeatedly confronting the memory or the trigger in a safe environment, the brain gradually learns that it's no longer dangerous. The intense fear response starts to decrease over time. The system learns it can stand down. And we know PE work studies from the VA show it's effective even for veterans who also have a mild traumatic brain injury, or TBI.
Okay, CPT changes thoughts. PE reduces fear through exposure. What's the third major one? EMDR.
Right. Eye movement desensitization and reprocessing, or EMDR. This one is a bit different. During EMDR, the person focuses on the traumatic memory while also paying attention to an external stimulus, usually bilateral stimulation like side-to-side eye movements or perhaps sounds or taps.
How does following eye movements help process trauma?
Well, the exact mechanism is still debated, but a leading theory is that the bilateral stimulation taxes the brain's working memory. This might make the traumatic memory less vivid and less emotionally charged while it's being accessed, allowing the brain to kind of refile it, process it more like a normal memory from the past, instead of something that feels like a current threat.
So those three, CPT, PE, and EMDR, are the heavy hitters.
They are generally considered the top-tier, most evidence-based psychotherapies for PTSD. Often, they might be supplemented with other approaches like broader trauma-focused cognitive behavioral therapy, CBT, or group therapy, which can be really helpful for sharing experiences with other survivors.
Now, sometimes therapy alone isn't enough, or people need something to help them manage symptoms while they're doing that hard therapeutic work. What role does medication play?
Medication is definitely used, but it's important to see it as a tool to manage specific symptoms, not as a cure for the underlying trauma itself. The goal is usually to reduce symptoms enough so the person can fully engage in and benefit from therapy.
Are there specific medications approved for PTSD?
Yes, the FDA has officially approved 2 medications specifically for treating PTSD. Both are antidepressants called SSRIs, selective serotonin reuptake inhibitors. They are sertraline, which is brand name Zoloft, and paroxetine, brand name Paxil.
Zoloft and Paxil. Are others used too?
Oh yes, other antidepressants are very commonly used off-label, meaning they aren't specifically FDA approved for PTSD, but doctors prescribe them based on evidence they help. Other SSRIs like fluoxetine, Prozac, or SNRIs like venlafaxine, Effexor XR are frequently used. These mainly help with the mood and anxiety symptoms, the sadness, anger, worry, irritability.
What about those awful nightmares we talked about? Anything specific for those?
There is. A medication called Prazosin is sometimes prescribed specifically to help reduce trauma-related nightmares. Interestingly, Prazosin is actually a blood pressure medication.
A blood pressure drug helps nightmares.
It works by blocking certain receptors in the brain for norepinephrine, that stress chemical we discussed. By blocking those receptors, it seems to help dial down the fight-or-flight response during sleep, leading to fewer or less intense nightmares for some people.
Does it always work?
It's important to say the research on Prazosin for PTSD nightmares is actually mixed. Some studies show good results, others less so. It doesn't work for everyone, but for those it helps, it can make a big difference in sleep quality.
Okay, now what about medications for the intense anxiety itself? Things people might commonly think of, like Valium or Xanax, benzodiazepines.
This is a really, really crucial point, and there's strong consensus on this from major health organizations like the WHO, the VA, medical schools like Harvard. Benzodiazepines, drugs like diazepam Valium, alprazolam, Xanax, clonazepam, clonopine are strongly discouraged for treating PTSD or even acute stress symptoms right after a trauma.
Discouraged. Why? They seem like they'd calm you down.
They might provide some immediate short-term sedation, yes, but the evidence shows they offer no real long-term benefit for PTSD core symptoms. Worse, they come with significant risks, high potential for dependence and addiction, cognitive side effects like memory problems, and maybe most importantly, because they essentially numb the person's ability to feel and process emotions, they can actually interfere with and undermine the effectiveness of the trauma-focused psychotherapies like PE and CPT, which require emotional engagement to work.
Wow. So they might feel like a quick fix, but actually get in the way of real healing.
That's exactly the concern, masking the symptoms short-term while hindering the long-term recovery process.
What about other substances people might try, like cannabis or CBD? Is there evidence there?
That's another area where we need caution. Right now, the scientific evidence is still considered insufficient to really support using cannabis or CBD products to treat PTSD symptoms effectively. Some studies even point to potential harms, like a condition called cannabis hyperemesis syndrome or potential worsening of anxiety for some. Research is ongoing, but it's heavily regulated and constrained. For now, the recommendation is generally to stick with the proven, evidence-based treatments.
Okay, so sticking with the evidence is key. Beyond those main therapies, are there other approaches, maybe complementary or emerging things that show promise for helping manage symptoms?
Yes, definitely. There's a big movement towards integrating mind-body practices. Things like mindfulness-based stress reduction, MBSR, which often includes meditation, and mindful movement like yoga or Tai Chi.
Why are those helpful?
Because they actively train the brain to do the opposite of what PTSD does. PTSD often involves either being stuck in the past, re-experiencing, or being hyper-alert for future threats. Mindfulness practices anchor you firmly in the present moment using your breath or body sensations. This directly helps calm the overactive nervous system.
Makes sense.
Yeah.
You also mentioned something called mantram therapy.
Yeah, mantram therapy is interesting. It's shown some success, particularly in reducing that feeling of hyperarousal, being constantly on edge. It's a pretty simple cognitive technique.
How does it work?
The person silently repeats a chosen word or short phrase, a mantram that has some personal, maybe spiritual or positive meaning to them. They repeat it silently to themselves, especially during stressful moments.
And just repeating a word helps.
The idea is that the silent repetition occupies the brain's working memory. It gives the mind something simple and calming to focus on, which can help interrupt the stream of intrusive, anxious thoughts or rumination. It provides a portable tool to kind of recenter and stabilize yourself when you feel overwhelmed.
We also saw some research on a medical procedure called a stellate ganglion block, or SGB. What's that about?
Right, SGB is considered an emerging treatment. It's definitely more invasive. It involves injecting a local anesthetic near a bundle of nerves in the neck called the stellate ganglion. These nerves are part of the sympathetic nervous system, the system that drives the fight or flight response.
So you numb those nerves.
Essentially, yes. The theory is that temporarily blocking signals through the stellate ganglion might help reset a chronically overactive sympathetic nervous system, kind of like rebooting a computer that's stuck.
Is it approved for PTSD?
No, it's not FDA approved specifically for PTSD yet, but there are ongoing studies, particularly within the military and VA systems, looking at its potential. It's seen as a possible option for people with severe treatment-resistant PTSD symptoms, especially hyperarousal, but it's still considered experimental by many.
Okay, let's talk about prevention. Because ideally, we intervene before the distress really takes root and becomes full-blown PTSD.
Absolutely. Prevention is key, but it requires a bit of a shift in how we, maybe culturally, tend to react to trauma. There's often this pressure to just be strong, push through it, get back to normal quickly, repress the feelings.
I know.
Exactly. But a crucial finding is that PTSD symptoms don't always show up right away. They can emerge weeks, months, sometimes even years after the traumatic event.
So, what should people do proactively? Say, after a serious accident, a natural disaster, the death of a loved one.
The proactive approach would be to seek out some level of support or psychoeducation relatively soon after the event, even if you think you're coping okay. Don't just wait for things to get bad. Prioritizing your mental health right away, understanding what normal reactions are, and knowing where to turn if things worsen, that's crucial. As one expert put it, you wouldn't wait months for a broken bone to maybe heal itself. You shouldn't necessarily wait for a fractured sense of safety to heal on its own either.
What helps build resilience? Why do some people recover naturally while others develop PTSD? Social support seems really important.
Social support is huge. Feeling connected, supported, understood by others right after a trauma seems to provide a powerful buffer. It helps restore that sense of safety and belonging that the trauma shattered.
What else contributes to resilience?
Other factors include having healthy coping strategies already in place before the trauma. Also, being able to find some positive meaning in your actions during or after the event, even in terrible circumstances. And interestingly, sometimes helping others who went through the same thing can be very protective. It can restore a sense of purpose and control.
Okay, so for someone who is living with PTSD, what are some practical self-care things they can do day to day to manage symptoms and maybe build some stability?
It really comes down to grounding and routine. Simple things can make a big difference. Gentle exercise is great. It helps burn off stress hormones and can lift mood. Setting realistic, achievable goals each day provides a sense of accomplishment.
In routine, you mentioned that earlier.
Yes, maintaining routines as much as possible, regular times for waking up, eating, sleeping creates predictability. In a world that feels chaotic and unsafe due to PTSD, routine can be incredibly grounding. It fosters a sense of stability.
What about connecting with others?
Definitely seek out comforting, safe situations and people, and joining a trauma support group can be invaluable. Sharing experiences with others who truly understand, who've been there, helps break down that profound sense of isolation that often comes with PTSD. And as we mentioned, practices like meditation, yoga, tai chi, anything that brings you into the present moment can help calm that overactive nervous system.
Finally, let's touch on supporting a loved one. Because PTSD doesn't just affect the individual, it ripples outwards, impacts the whole family, relationships.
That's so true. Supporting someone with PTSD can be challenging. Maybe the most important piece of advice for family or friends is try to be a listener, not necessarily a fixer.
What do you mean by that?
Offer them space to talk, to vent their frustration or anger without jumping in with solutions or judgments, unless, of course, there's a safety concern. Sometimes the person just needs to release that intense pressure. Simply being present, validating their feelings, that sounds incredibly hard. Listening without trying to fix the unfixable trauma, that can be incredibly powerful.
And helping with that routine we talked about.
Yes, gently helping them establish or stick to routines can provide that external structure and stability when their internal world feels chaotic. Also, really importantly, respect their boundaries.
Even if they don't clearly state them.
Especially then, don't push them to talk about the trauma if they're not ready or don't want to. Let them lead. Support them in finding healthy coping skills rather than, say, enabling unhealthy ones like drinking too much. Guide them towards resources. Maybe help them find a support group.
And the person doing the supporting needs support too, right? Compassion fatigue sounds like a real risk.
Absolutely essential. Caregiver self-care is not a luxury, it's a necessity. Living with and supporting someone who is constantly hyper-aroused or emotionally withdrawn is incredibly taxing. Experts are clear, compassion fatigue is real. Caregivers need their own support systems, friends, family, maybe their own therapy or support groups specifically for partners or families of people with PTSD. They need to recharge their own batteries to avoid burnout.
This has been, wow, such a detailed deep dive. We've covered so much ground, from definition and symptoms to the brain science and treatments. I think the biggest takeaway for me is really driving home that PTSD isn't just psychological weakness. It's a real physical injury to the nervous system.
Exactly. It's a profound neurological and biological response to overwhelming threat. And the message we really want to leave people with is you are not alone in this. There are effective treatments out there, especially the psychotherapies like CPT, PE, EMDR, that really work on the core issues and don't just rely on medication. Reaching out, recognizing there's a problem, that's the first brave step towards getting better. Help really is available.
And if you listening or someone you know is struggling right now, especially if you're having thoughts of harming yourself, please reach out immediately. Remember the resources. You can call or text the Suicide and Crisis Lifeline anytime at 988.
That's 988.
And if you're a veteran in crisis, you can call 988 and then press 1, or you can text 838-255. These services are free, confidential, and available 24/7. Please use them.
Please do. And, thinking about everything we discussed today, especially that powerful research linking PTSD to chronic inflammation, endothelial dysfunction, and those increased risks of heart attack and stroke, it really leaves us with a final, maybe provocative thought to consider.
Okay, what's that?
Given this evidence, how does our healthcare system need to change? How do we move beyond treating trauma primarily as a mental health issue, siloed off in psychiatry, and start treating it as the systemic public health crisis it clearly is? One that affects the entire body and likely requires integrated care, primary care doctors, cardiologists, mental health professionals all working together, maybe right from the start after a traumatic event.
That's a huge question. Treating the whole person, mind, and body right from day one. Definitely food for thought, and it would require a major shift in how medicine is practiced. Thank you so much for sharing all this vital information today.
Thank you for the conversation.
And thank you all for joining us on this deep dive. We'll be back soon with more insights from the cutting edge.